breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos, my co-host, Dr. Glenn Harrison, the one, the only. How you doing, bud?
I'm doing well. I'm doing really well. How are you doing on this fine evening?
Good, man. I'm good. Yeah, it was a good day. A little busy. That's okay.
That's good. That's good.
I've actually been pretty amped
anything?
up about this.
Did you learn anything?
Man, you learn something new every day. You know.
Yeah. Did you see any really bizarre neck pain today?
Oh man, you just segueing me right into this.
Every day.
Yeah.
But was it this bizarre?
It might be. I mean, I saw this today for sure.
Okay,
This is why I was pretty juiced to talk about this today, because this is something that I actually really, really like to see in practice, because there's a lot of people that are like, well, it's challenging, right? But then there's also a lot that you can do for people that they don't even know is a possibility. Mm-hmm. And what we're talking about today is neck pain that's unresponsive. This is neck pain where you've been everywhere. You've been to a chiropractor, you've been to a physical therapist, you're doing stretching, you're doing, massage therapy, you've done injections, and it just never goes away. Mm-hmm. And we're going to talk about some possible underlying causes and some things to consider with your unresponding neck pain. So if this is the first time that you've watched or listened to the videocast/podcast, and you get value out of this information that we present to you today, turn on hit like and subscribe, and turn on notifications, because we're going to continue to roll out new content every week, and you never know when it's your condition that we break down next. So without further ado, man, let's talk about neck pain.
All right. So how do we define neck pain? What are common symptoms?
Yeah. So when I look at neck pain, anyone who comes in and they're like, "Ooh, I can't turn my head side to side. I've got a lot of chronic tightness. I've got some burning and radiating pain that moves into other areas of my body." I'm like, love it. Let's do it.
And what about some things here? I know we were writing notes on this, active versus passive movement, and how does that play?
Yeah. So someone this is kind of a good differentiating point for a lot of people, is like, I can't turn my head, but when someone else turns it, they can turn it. Right. So they try to turn their head. It's like this, very limited range of motion. Then all of a sudden someone grabs it and moves it for it. Then they have full range of motion. That can be really clinically relevant, because it's not some actual sort of joint dysfunction or arthritic changes or something like that, because if it was that, then there should be limited mobility even during passive range of motion. So
sure. So when you get, because I'm gonna hit you with 101 questions, because I'm not working with this stuff. Well, some of it, but not necessarily the way you are. But when someone walks into your office and says, I've been everywhere, Dr. Kolby. Well, I don't know. And you get the doctor burnout patients where they're like, they've been everywhere and they're frustrated. Of course they're frustrated. And they come in, and then the doctor, you or I, have to, okay, I know you're frustrated. Let's just see what's going on here, and take a big deep breath and let them tell their story. What are you considering? What is your first train of thought when they come in and they tell you that, they've been everywhere and their neck's still problematic?
So my first step is I always start at square one. Mm-hmm. And I never take someone else's diagnosis, and I never take, I like getting the notes from previous providers, but I don't ever read them until after I've seen the patient, right? Yeah. So I always start at square one, right? So I always want to do the most complete history for the patient, because you never know what minute detail might actually help you come to some of the causes. So when I look at people like this, I do a really thorough history as far as were you in any car accidents? I don't care if it was yesterday or 15 years ago. Have you ever had any brain injuries where you lost consciousness or otherwise? Is there any sort of underlying inflammatory condition like arthritis? And then you can start to kind of build this clinical picture that kind of helps you, put all the pieces together so you get a kind of a view of the puzzle. Then I ask them, did your symptoms become slowly? Did you slowly lose your range of motion? Did you slowly begin having these radiating pains? Did you slowly develop these tension headaches? Or was it really, really rapid onset? Did it occur after a condition, right? Oh, I was in a car accident. Now I can't turn my head. Oh, I was hit in the head during a football game, and now I can't turn my head, and I have severe splitting migraines and chronic neck pain. Yeah, so there's a lot of things you can do just from the history to kind of piece together when all this stuff happened. And that's like step number one for me when I treat my patients with this type of stuff.
Get a proper history and find, what the onset was. Was it immediate? Was it instant, or slowly progressive over time? Now, what are some of the, we talked about causes, but then some of these injuries, I know we were talking about writing notes here, concussions and structure damage, instability naturally, but you're going to find that in an exam mostly, right?
Yep.
So not necessarily concussion. The effects of a concussion, I guess.
Sure.
But then you talked about something that was interesting. This is where we get in the neurology, where you talked about altered perception of your own body and perceived instability. Unpack that.
Yeah. So again, like we talked about concussions, right? Structural damage. This could be like whiplash, right? Mm-hmm. And a lot of times concussions actually can mimic whiplash, or you could have both, right? When we talk about altered perception of your body and with perceived instabilities, basically what I mean by that is like your brain's pretty dang important, right? It's this big 8-pound ball of butter sitting in your cranial vault sitting on top of your neck, and it controls everything. So your brain wants to make dang sure that it's safe. So if for whatever reason your brain is perceiving your neck as being unstable, right? It's going to shunt those muscles in your neck, and that's to prevent further damage, right? The last thing your brain wants to happen is you turn your head and your neck's unstable, and then all of a sudden there's a big problem, right?
So your brain is activating muscles due to a dysfunction in the brain,
right?
An injury, a concussion, something.
Or it could be truly like that it isn't able to perceive where your neck's at, right? It has altered perception of where your neck's at in space or in relationship to the rest of your body.
But this altered perception, this altered proprioception, if it is, that where does that come from? That would be some form of brain injury or something like it, would it not?
Could be brain injury, or it could be damage to the neck, right?
Oh,
so
okay.
If you actually damage your neck and your brain's like, oh man, it's damaged, and it's been for so long, then you can actually perseverate that. So then all of a sudden your brain's like, it was been unstable for quite a bit. Even if it's not unstable anymore, like we're just going to limit the mobility because we really don't want to cause any damage.
It's safer.
Yeah, it's safer, right?
Okay. Now there's lots of there's lots of, you talked about one thing. I'm going to get you to unpack that too. Central wind-up mechanism. What is that?
So basically, you have pain, right? And you fire this pain pathway over and over and over and over and over again. And your brain becomes very, very efficient at accessing that pain pathway, right? I kind of use the analogy of like, if a bunch of cars are going to use a road and it's a dirt road, they're going to pave it. If a lot of cars use the paved road, they're going to make it a highway. If a lot of cars use the highway, they're going to make it a 4-lane highway. And basically what it is the more it uses this pathway, the stronger and more efficient it gets. Right. So if you are consistently firing this pain pathway over and over and over again, it becomes very efficient.
It'll take less irritation to have the same amount of pain.
You got it. So then all of a sudden, instead of being able to turn your head like this, well, you turn it and it alters that pain, or it fires that even a little bit of that pain perception, and the whole thing goes right. So then all of a sudden, oh wow, my neck really, really hurts, and I didn't do anything. But just that little bit of stimulus can actually cause a big global effect, because that pathway has been,
the Turkey Trail pathway is now like a super 10-lane highway.
Yep. Basically. Yeah.
And now there's lots of causes to these, unresponsive pain, if you will, neck pain. What are some of these?
So as far as like, when I look at unresponsive, right? So, or how's this? How about overly responsive neck pain, right? It could be one or the other. Like, I've tried everything and it doesn't respond, or all of a sudden they're like, I've tried everything and it gets significantly worse after all of it, right? Because there are those two ends of the spectrum. And what I look at when I break it down is, so a lot of my exam is going to tell me a lot about this, right? So I do a really, really, really thorough neurological exam where I break down a cranial nerve exam. We do a cerebellar exam. We do a frontal, we do all these different exams. And what I'm looking for is aberrancies, right? And I'm just going to pick a couple of things that we can go over. So when we look at the aberrancies, it can be an aberrancy of where they're perceiving their body at, right? So if you have alterations in your perception of your body, then you're going to have alterations in your body, on your body. You're going to shunt muscles in a certain way, in a certain pattern, because you're trying to make these mismatches fit, or you're trying to prevent injury and damage.
So just to unpack that. So if if you're unaware of the position you are in space, there's instability, and if there's instability, your brain gets confused, and it's going to fire many different muscles to try to maintain structure and order and balance, if you will.
Yeah, and limit the possibility of injury, right? Because your neck's pretty dang important.
Yeah.
In some instances, you'll see people who have aberrancies or deficits in eye movements, right? Mm-hmm. And what they do is they will actually substitute those eye movements with their neck muscles, right? If their eyes are moving all the time and they're trying to look at someone, what they're going to do is they're going to move their head the equal and opposite direction so that they can maintain basically their ability to hold their eyes on the target.
Yeah.
So you think about it and you're like, man, my neck is chronically tight. No matter how much I stretch it, it doesn't ever improve. I've gone to physical, blah, 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 blah. It never gets better. Well, maybe it's not that the muscles are actually tight, but, or explore why the muscles are tight in the first place.
Mm-hmm. The brain is turning them on repeatedly.
Yep.
From another neurological condition.
I mean, it can be alterations in vision, visual inputs. It can be alterations in vestibular input from like your inner ear and your cerebellum, that coordination of stuff. This is why getting a really, if it's unresponsive, this is what I would recommend to people. If you have chronic neck pain, getting an exam with someone who looks at it through a different set of lenses than what you've tried previously would be totally invaluable, because there's a lot you can do with people and they don't even realize that it's a possibility.
Mm-hmm. Yeah. It's when, the other forms of care are kind of they're hitting a roadblock, they're hitting a wall with their outcomes. Now, structural, of course, there's a lot of structural conditions. What would some of those be? I know we would want imaging to find out does it exist versus just getting a bunch of manipulation.
Yeah, for sure. I mean, and there are cases where it is going to be unresponsive because of structural damage, right? If you had a fracture in your neck and all of a sudden your neck is fused, or you have to have a fusion in your neck, you're not going to be able to turn your head as much as you should. If you had, whiplash injury or whatever, or even like tech neck, right? So we have alterations in posture because of lifestyle stuff. That's where imaging would be important. That's why it's important to getting a very thorough history, doing an exam, trying to let the exam and the history dictate where you go next, right? If there's nothing that dictates that, then you probably don't need it. But if it is, and you're like, oh, this could be a structural component, getting an x-ray, getting an MRI, getting that kind of stuff would be totally invaluable as well. If you have any sort of inflammatory arthropathies, they can sometimes move to the neck as well. So really exploring that as far as if you have some sort of inflammatory arthritis, if you have some sort of autoimmune disease, sometimes those can move to the neck. But yeah, those are all things that you need to explore.
Even viral issues sometimes can migrate to certain joints and create this issue, this inflammatory cyclical response. You might get some temporary improvement with musculoskeletal work, but it never goes away.
Mm-hmm.
Yeah, you see quite a bit of that. I've seen shingles flares do that all day, every day. When there's a flare or an episode. Break down briefly if someone's got this going on. Where would they go? What would they do? And what would that look like?
Sure. That's a big question, buddy.
where can they go?
Yeah. So if you're someone, it's not acute, it's chronic and over again, it's not
over 3 months, at least over 3 months of symptoms. I
would look at finding someone who integrates all the pieces together, right? So they start at square one. They don't take anyone else's word for it. And they're going to look deeper than structural, right? Because structure, something's got to move the structures, right? And that guy is the brain. Mm-hmm. So if they've tried addressing it structurally, we've adjusted it. Yep, we've strengthened the deep neck flexors. Oh, we've increased your cervical curve. Oh, we've done physical therapy. We've done massage. We've done all this stuff. We've looked at all the options to help with the structural component. Then it might not be structural. Mm-hmm. Excuse me. So then I would look at someone who has a little bit more knowledge as far as the neurology of it, right? So, or look at the different mechanisms that control the neck mechanics, right? What controls the musculature of the neck? Well, it's the brain, right? Consider that it might actually be a pain windup. You know what I mean? Something like complex regional pain syndrome. We've heard that before. I don't know. Have we done a podcast on that?
No.
That might be something we do. But looking that it could be something that like, yeah, this is fired over and over and over again over time. So it's really, really sensitive, really, really efficient. And then consider alternative therapies. You know, if you've done all the structural stuff, you've done all the injections, you've got MRIs, you've got x-rays, all of it look normal. No one can explain why your neck is stiff, why you're still getting all this chronic pain, stuff like that. Then you can look at someone who has a different set of lenses or a different set of tools and applies different therapies. You could see a functional neurologist like myself. You could try acupuncture, vestibular therapy, vision therapy. I mean, biofeedback, there's a ton of stuff.
Yeah. Yeah. So looking, if it's not working, if someone's been dealing with all of this, there's still hope. There's still a lot that can be done. And hopefully this episode was able to shed some light on that and some other causes that probably were missed.
Right. And this wasn't probably one of my most organized podcasts as far as like my thought process, because I'm kind of bouncing all over the place. Mm-hmm. But if you guys have questions, yeah,
the way it has to be.
Because there's not really one. Everyone wants the magic bullet, right? Everyone wants if you have chronic unresolved neck pain, look here. That's just sadly not going to be the case. But at least maybe now you know that there are some people out there that'll look at it a little bit differently. And again, if you have questions, you can reach out to us. Our contact information is info@brainstormingwiththedocs.com. My website is www.northlakeschiropractic.com. Dr. Glenn's is www.drgharrison.com. And yeah, I mean, if you have questions, reach out to us. We'll do what we can. If we can't help you, we'll put you in contact with someone we believe might be able to help you.
Sure.
And don't give up hope, because there's a lot of people that I've helped with this that had kind of given up hope already, and that just doesn't need to be the case.
Yeah. Well, that's awesome, Dr. Kolby. Thank you very much for that. And I guess that's a wrap.
That's it. I hope.
All right. All right. I look forward to talking to you at the next one.
All right, buddy.
Bye-bye.